And I have 11 o'clock, so we'll go ahead and get started for today. I'm Becky Royer. I am a consultant for the Indiana Hospital Association and the lead for the Medicare Beneficiary Quality Improvement Project. And you've joined the MBQIP Flex Quality Networking call today, which we're going to be focused on HCAHPS scores. HCAHPS has definitely had some impact from COVID over the past year. And many of the critical access hospitals have been working on different improvement initiatives. So we've asked Stratus Health to join us today to kind of share what they've been hearing from a national perspective on improvements to HCAHPS scores, understanding some of the impact of COVID, and also going to be sharing some information related to ED satisfaction scores as well. Many of the critical access hospitals have discussed some concerns around lower scores in that particular area too, and definitely for critical access hospitals is very important. So joining us from Stratus Health, who is our MBQIP support center across the country, we have Janelle Shearer. Janelle is the quality improvement specialist there at Stratus, and she has a lot of extensive experience leading quality improvement initiatives, both on a local perspective, regional perspective, and statewide perspective on a multitude of projects. I included her complete bio in your calendar invitation for today, so please read through that. Janelle does hold an MA in nursing from Bethel University and a BS from the University of Iowa, and she's an adjunct faculty at Bethel University in the RN to BSM program, on top of all of the help that she provides there at Stratus through the MBQIP program. But Janelle's very dedicated and has a passion for rural, so we want to welcome her today. Please open up your chat. If you hover, I believe for most people, if you hover at the bottom of the screen, it will bring up a bar where you can open chat up. We would love for you to include your name and the hospital that you're with, particularly if you have more than one person in the room, so we can take as accurate attendance as possible on Zoom platform. Also, we would like for you to open up the participant list too. And if there's someone that you would like to reach out to and chat individually with, why you'd be able to do that as well. So at this time then, I'm going to turn it over to Janelle and we'll get started with today's program. Janelle?
Thank you, Becky, and hi, everybody. Thanks for having me at your meeting today. Like Becky said, I love rural. So I was raised kind of in the upper Midwest, mostly in a town or in a city. But then when I got married, I married a farmer. So we lived in Southwest Minnesota on a farm for, I don't know, like 20 some years. And then I don't know if anybody here has been in that kind of work, but when things weren't going so well, we ended up selling and moving to the Twin Cities, living in the suburbs, kind of like a far suburb. So I worked in a rural hospital where I spent most of my career, or all of my clinical career, for 18 years, working in a variety of departments. The last being, I started and then directed their home care and hospice programs for about 10 years before we relocated, and then I started working at Stratus Health. But just this weekend, we moved out of the suburbs and into an acreage. So we built our downsizing house and have 10 acres here, and it's nice and quiet and peaceful. I think it'd be considered rural, although I'm probably like 20 minutes from a shopping center, and I'd say maybe 40 minutes from downtown Minneapolis. But anyway, I love it out here. So. Stratus Health, just a little bit about the organization I come from. Stratus Health is a independent nonprofit organization. We're based in Minnesota, the Twin City metro area, but we have staff nationally, and we do a lot of national-based work. We work at the intersection of research, policy, and practice, really meeting collaboration and innovation to drive healthcare quality and patient safety. And we work across the spectrum of care. So I get to work with all different kinds of practice providers in different settings. So hospitals, nursing homes, assisted living, home health agencies, etc. But we have a particularly long history of working with rural providers, both within Minnesota and nationally, including critical access hospitals and the Medicare Rural Hospital Flexibility Program and the 45 state flex programs. So just a little trivia that if you want to participate this in chat, in the US, we have 45 state flex programs, which means there are 45 states that have critical access hospitals. So if you'd like to weigh in and chat and see if you know or can guess the 5 states that don't have a state flex program, go ahead and do that, and I'll give you the answers at the end. And some of them are kind of surprising. So I'm here today specifically with the hat that Stratus Health wears, serving as the Rural Quality Improvement Technical Assistance Center, or ARQITA. And let me tell you, there are new acronyms in this program, which you probably heard many of these already. But sometimes you'll hear us referred to as ARQITA or Stratus Health interchangeably in this national flex world. And this is a cooperative agreement that we have with the Health Resources and Services Administration Federal Office of Rural Health Policy. So FORHP, as it's known, it funds your state flex program. It also funds us and how we get to work with the state flex programs and with you all. So in our role as ARQITA, we again put on that quality and patient safety hat focused on improving health outcomes, specifically for those folks in rural communities. And today we're going to talk about the Medicare Beneficiary Quality Improvement Project, or MBQIP. Our objectives today are we will explain the importance of the emergency department and hospital consumer assessment for healthcare providers and systems, HCAHPS, surveys for critical access hospitals. And HCAHPS is also known as the patient experience survey. I mean, I just usually refer to it as HCAHPS or HCAHPS or EDCAHPS, but to list out all those words that the acronym stands for. We're going to explore the questions in each survey because it's really important to know what patients are being asked about and to think not just how they're being asked, but how they're being asked to answer the questions, because they're given answer choices. And so that's really good information for you and your staff to have. We will identify best practices to improve the experience scores for patients in ED and inpatient settings, and then discuss best practices related to patient and family engagement during this COVID-19 pandemic. So I want to hear from you too, some of your best practices that you've been utilizing. We'll start with an overview of the patient experience in MBQIP. So you know that through your state flex program, you're asked to participate in the Medicare Beneficiary Quality Improvement Project, right? This initiative at MBQIP is where at the federal level, through the Federal Office of Rural Health Policy, they set a common set of rural relevant measures and ask critical access hospitals nationally to report on those measures. Then the intention is that the adage in quality is so that you can't improve what you can't measure. So you start with quality measurement. So that's first. And then based on that measurement, we can identify opportunities for improvement, ensure that we're making all that improvement to our quality initiatives. And then ultimately, the reason we're all here is to improve patient outcomes. We also want to be preparing critical access hospitals for participating in value-based payment programs. Although CMS doesn't currently require critical access hospitals to report on their quality measures or pay them based on their performance measures yet. But we know that where CMS leads, other payers follow. And many of you are likely already in some sort of payment arrangement with your insurance or Medicaid programs related to quality. And so this is an opportunity for the Federal Office of Rural Policy to support you in your quality reporting and improvement adventure through technical assistance that's provided through your state flex program. So why are HCAHPS something you want to be talking about? What CAHPS really are is a family of surveys that's developed for measuring patients' perception of care. Prior to CAHPS existing, there were a lot out there, and actually there still are a lot of patient experience or patient satisfaction surveys related out in the field now. But what CAHPS did was really standardize the survey and the methodology so that all of us are using the same approach to how we are collecting and analyzing and measuring the responses that we get from patients about their experience in various aspects of care. So in addition to EDCAHPS and HCAHPS, which we're going to focus on today, there are the CGCAHPS, the clinician and group that would be used in your clinics and ambulatory settings. There's the OAS CAHPS, which is outpatient and ambulatory services, which is if you have ambulatory service centers and things of that nature. Then there are home health CAHPS. So there's a whole array of CAHPS, but today we're focusing on ED and hospital. But just know that it's a full family survey of surveys. And it's an important driver of performance improvement related to patient perceptions. Your PPS counterparts, they're paid not only for the requirement that they complete HCAHPS, but they're paid on the performance of HCAHPS. So it's part of value-based purchasing program for PPS hospitals. Home health agencies are paid in part based on how they perform. EDCAHPS don't have a standard mechanism yet for national reporting, but that's something we hope that will come to fruition in the future. But we know that while you, let's say, quote unquote, aren't required by CMS to report these, you do report your HCAHPS, for example, because it's part of the MB-QIP that you're reporting, so that others, the others are actually paid for performance, but you're required to do them because of the MB-QIP survey or program.
Janelle, this might be a good time to address this particular question, but I am asked from time to time if there is eventually going to be a critical access or a rural provider CAHPS, since there are differences in care.
Yeah, that's a great question, and one that I don't know. But you know what, I will ask my colleagues at Stratus Health because they have a little more experience than I do with this, but that's a great question. And I know one of the things that we keep promoting and wanting is rural relevant metrics for hospitals, such as those on the call, because, they remove some of the measures that were pretty relevant, and we keep advocating for ones that are really important. And Becky, please interrupt me whenever there's a question or any comment. So I'm totally fine with that. Or if anybody,
Great. Thank you.
Is there anything else right now?
No, that's it.
Okay.
That's the question that I was often asked, and I thought this would be appropriate time to address it.
Yep, I'm writing it down, and then I'll just send you email follow-up and you can forward that on to folks.
Okay, thank you.
Yep, sure. Okay, so a little background about HCAHPS. It was developed by the Agency for Healthcare Quality, Healthcare Research and Quality, and it offers the ability for comparing performance with other hospitals because it's standardized. So the fact that all of the hospitals are using the same standard set of questions and the methodology for rolling out the survey is very stringently driven. That means that you can actually compare with some risk adjustment to say, well, how is this hospital performing with regards to patient experience compared to another hospital? And we can look at hospitals on opposite sides of the coast, at different regions of the country with different patient populations, and so on and so forth. The broad goal for HCAHPS are for producing that comparable data on patient perspectives, and then public reporting that's designed to create some incentives for hospitals. So your HCAHPS scores, if you have sufficient volume, are publicly reported on Care Compare. That means, as a patient, you have options of where you can go to get your compare. You can go out and look and see how this hospital performs for patient experience compared to another. And, this is something that as a consumer, I would actually do and have done. And as I mentioned, CMS has required this for PPS hospitals since 2007 is the year that they started that. And it's a core measure for critical access hospitals for the MDQIP, as we talked about. And it's also a requirement, and I think it's still a requirement for the federal SHIP dollars that you're eligible for being a small hospital. And CMS rolled out each HCAHPS star rating in 2015 for all hospitals that have more than 100 completed surveys in rolling 4 quarters. Often we find that critical access hospitals don't have, they might not meet that 100 completed survey threshold, but if you do, then you're eligible to receive an HCAHPS star rating based on that performance. And it's included in Care Compare as well. So the EDCAHPS was developed by the RAND Corporation in collaboration with CMS. It's in the public domain and available at no cost, but there's no standard reporting mechanism for it yet. So while with HCAHPS, you report the data to CMS through either the hospital quality reporting portal or your vendor, if that's what you use, there's no standard mechanism for actually submitting EDCAHPS in any centralized system. So while it does offer standardization of the survey questions, we don't have the comparative data yet to compare, one hospital to another. It creates the common set of metrics and national standards for collecting the data, but hopefully sometime we'll have the comparative data available. So we're going to dig into all of these in much more detail, but we wanted this slide just to show you a quick side-by-side of the way the EDCAHPS and HCAHPS surveys are set up into what we call domains or composites. So these are at the high-level categories of the types of questions that are asked on the survey when we're looking at patient experience, and we'll dive into them much more detail as we go through. So I won't read them, but you have them for your reference for later. We're going to dive into the questions as we think about suggested strategies. So as we go through the different questions, if your hospital is doing something unique or different, or just doing a best practice, go ahead and put that in chat, and Becky, then go ahead and if you would just share that with us all. So first and foremost, in order to be able to improve on your patient experience, you need to get responses from your patients. So we have to talk about response rate, and what does it look like to ensure that patients are responding to the surveys? Are you actually getting meaningful feedback back? Because that's what you want, is a high number of responses. And then there are some different modes of survey implementation and how they're different across the CAHPS survey types. So between the HCAHPS and the EDCAHPS, for example, HCAHPS has mail only, telephone only, a mixed offering where you send a survey out by mail, and then if they don't respond, you do a telephone call. Or there's the option for the interactive voice response, which is over the phone. So rather than actually talking to someone, giving you the survey, you are punching in numbers indicating your answers. I know my husband just completed one for a clinic visit he did recently. For the EDCAHPS, they have some different modes available. They have a standard mixed mode, which is a mail survey with a telephone follow-up call. And then they have a web telephone mode, which is an email survey with a follow-up call. They have a web mail telephone mode where they do the email survey and then they send it by mail, and then they do a follow-up by phone. So email and web-based surveys is currently not an acceptable way to administer the HCAHPS, but I'm hopeful that given they use it for EDCAHPS, that it will eventually be available for HCAHPS as well. So I'm wondering if you could put this in chat, what modes are your hospitals using to administer your surveys? Are you using multiple or just one? And also if you know if they've been, if it's successful.
And again, to open up chat, just hover at the top or the bottom of your screen, and it will bring up the bar that you can click on.
I guess I could click on chat too myself.
We have some mail.
Okay, great.
Doing a mixed.
Yeah,
Or
okay.
mixed, yeah.
Next, okay, great. And I know, at least for like, maybe it's all of them. I haven't had a hospitalization recently, but a clinic visit, and I didn't do it right away. I was thinking about it. And then when I went back to respond to an email survey, it was no longer available. So there must be a time limit as well.
Yeah, looks like we have a hospital that's exploring My Chart and Epic for reminders to complete the survey. And their goal and recent changes are now electronic only, not snail mail.
Yeah.
Another hospital is doing HCAHPS by mail only, and ED, they're doing a mixed.
Okay. Yeah, it's curious also to see, are there different communities where people respond better to one or the other, because I would assume it wouldn't be the same for everybody. Thank you guys for sharing. Appreciate that. Okay, so when you're thinking about your surveys, it's really important, right, that you have responses, because if you only have a couple of people that respond, it's not going to give you as much information as you would like to be able to have to inform your patient experience interventions. You want to make sure that you're telling people about your survey. So well, another question for you, how are your hospitals telling your patients about the survey that your patients will be getting one? What are some things that you do there?
And we'll give everyone just a couple of minutes to enter that into chat.
And I promise I won't be asking you to do this all the way through. We'll never get it done, but I would love to just hear, some of the things that hospitals are actually doing.
I know that in several of the hospitals I've been talking with, more and more it's being discussed during that leader rounding.
Mm-hmm.
Yep, their leader rounds, follow-up phone calls, discussing it at discharge.
Great.
Encourage therapy staff to alert patients that they will be receiving a survey at discharge. Great idea, particularly from the swing bed areas. Another hospital is discharge planning, flyers at discharge, and follow-up phone calls.
Awesome.
Yeah.
So I'm just looking at the notes on the slide. So it sounds like some hospitals are covering it. So like during discharge planning, and you talk a lot when you do discharge planning, there's so much information that you give, but telling about the survey is a great idea. People need to hear it multiple times and actually multiple ways. So flyers and brochures, some hospitals put posters, it might be on their website, it might be announcements here and there, or coming on the waiting room screens or the patient screens where you can give some announcements. I've also heard about hospitals that when they do, say you do a discharge follow-up phone call within 2 or 3 days after discharge, it's a good time then to remind them also about the survey, because they're in a little better headspace after they've been home for a day or two, and you're not giving them all the information about the meds and what they're supposed to be doing. The leadership rounding was also mentioned. So that's a great way to, assess how are things going right now. And then also to let you will have this opportunity, and we really do value your feedback. I think that is really powerful when leaders can share that with patients.
I know excuse me, Janelle. I know we also have some hospitals, and it reminded me with the comment in chat there, asking what number they would like for the hospital to use for those follow-up phone calls, that some of the hospitals are working to make sure that the patient caregiver or their care partner is also aware of the survey and discharge instructions, because they are often the person completing it for the patient.
Yes, great point. And to let your patients know how is it coming. So if it's an email, who would be coming from? If it's a phone call, I don't answer my phone normally on a number I don't recognize, because it's mostly junk. But that's really helpful to get a response, so people know to look for, okay, yep, they did say it'd be coming from, or that, that's what it would say on my iPhone, who this or what the number is, something like that. Some great points. Okay, so when we look at how the questions are rolled out, and the reason this is a patient experience survey instead of a patient satisfaction survey is that they're not asked to rate their satisfaction. They're asked to indicate an answer to a series of questions. And the questions have what we call a top box score. So as we go through the questions on the following slides, you'll see that the top box score is provided in green. So here you see, like on the first one, never, sometimes, usually, always. Always is the top box score, which means that's the score you actually get credit on. And so there are a variety of ways that folks have offered to answer the questions. The most common answer choices for HCAHPS are to say, how frequently did something happen? Was it always, usually, sometimes, or never? And you'll get, so in this case, you would get the credit if they answer always. So for any of these, to get the credit, you need that, that green one. If they don't answer always, you don't get credit, but you do get information. So say your people are responding that something happens like usually or sometimes, it gives you information on where you have opportunity to focus on, but you just don't get the credit for it. Some of the questions are framed in a yes or no dichotomy. Some are framed slightly broader, no, yes, somewhat, and yes, definitely. Some are even broader still with definitely no, probably yes, definitely yes. And then there are a few questions on the Likert type scale, such as strongly disagree, disagree, agree, strongly agree. And then there are some questions related to the emergency department that has to do with timing. So the top box score there is less than 5 minutes. And I think the question is, how soon did someone check in on you or something like that? So they have like 3 choices, but the top box score is less than 5 minutes. And then this will all start to make more sense as we go through the questions and you start to see how the answer choices align with the questions. So let me just stop a little bit. Any questions so far to see if is there anything in the chat, and does it make sense so far? And I'm kind of giving you the background on the.
None at this time, but I do appreciate the background because we have a few newer quality improvement leaders in several of the critical access hospitals. So thank you for doing that.
Yeah, and it's just helpful to understand the surveys better if you kind of realize that the answers are not just all the same, they vary. And then even between the different CAHPS surveys, they vary. Okay, so we will talk about the improvement strategies first. So on the next slide, you'll see as we go through all the remaining slides, on the left hand, we have a little code there, E for ED, H just hospital, and then H/E when it pertains to both. And so you'll see like on the next slide or so that's how you know which questions pertain to which survey. Okay, so for EDCAHPS, and the domain is getting timely care. So we're gonna jump into that first. And this is one of the composite or domain areas for EDCAHPS. The questions are when you first arrived in the ER, and they call it ER to patients because that's what they're used to, although we call it ED, emergency department. They say, how long was it before someone talked to you about the reason you were there? And the top box score is less than 5 minutes. And then during the ED visit, did you get care within 30 minutes of getting to the ER? And the top box score is yes. So when we're thinking about timely care, there are 3 main concepts: communication, reception, and alternative patient flow. And we're going to dig into those here. These are going to tie into some of the other emergency department throughput measures for MBQIP that have to do with how long does it take to get through the emergency department from the point of arrival to the point of discharge, and then how many patients leave without being seen. And that presumably has to do with how long it takes for them to get in. And because, and then patients, if they're not waiting long enough to be seen or it's taking too long. So some of these factors can play into some of the other MBQIP measures as well. So when we think about communicating, it's really important when it comes to timely care because we're setting expectations. And we want to make sure that we're under promising and over delivering and providing updates. So I've actually heard the opposite of that statement quite a while. Like I said, we've just built this home and we've decided that our builders should have on their website ad over promise and under deliver. But what you want to do is under promise and over deliver, and you will have much happier customers. So any of us who's ever been a patient in the emergency department, you know that 5 minutes feels like 5 hours. And for anybody who's worked in a busy emergency department, you know that 5 hours feels like 5 minutes. So our perception of what is happening in a busy emergency department is totally driven by the role that we're playing. Are we a patient or are we a staff member who's in a busy space? So you want to be clear about setting those expectations, under promising and over delivering. If you tell me it's going to be 20 minutes, at 21 minutes, you know, and I haven't been called back yet, I'm going to be like, it's been 20 minutes and I'm still sitting here. But if you told me it's going to be a half an hour and I get called back at 21 minutes, I'm going to be really grateful that it happened faster. And then providing updates. So if you gave an estimation and it was incorrect, go back and let them know, hey, something's going on, or, you know, something came in, you know, nothing, not to concern about the details, but just to let them know and level set with the folks so that they know why their wait might be a little bit longer than anticipating. And then arranging the space in the reception area so that folks have their own space. So especially when we're thinking about and this is true about all the time. I know, you know, think about pre-COVID. I had the same kind of thought that got exacerbated during COVID. If I have a family member who needs to be seen, you know, in the ED, and we just go and sit with this whole big group of people, well, I really wouldn't be too crazy about that, right? I want to have like my own little space. Like, do I want to expose myself and my family to others who are sick? So you want to create little alcoves where folks can have their own space within that reception area that can really, really help a lot with their patient experience. And then the next suggestion is removing the term waiting from the vocabulary. So the idea of setting up a reception area rather than a waiting area in the emergency department is a thought. So just taking the term waiting out entirely, taking it out of your signage, remove it from your vocabulary if possible, and think of ways to integrate different ways of framing it. And then giving people things to occupy their time. So I think a lot of emergency departments do a good job on this, and they've been doing it pretty well. But if you weren't thinking about it, do you have like magazines out there, books or toys for kids or TVs, you know, to occupy their minds while they're waiting because they're going to be, you know, they're typically going to have to wait a while in the busy emergency room. And then think about alternative patient flows. Do they have the ability for the nurse to do a preliminary triage registration, you know, immediately upon arrival? So the people that have just like little things, can you get them in and out rather than having them wait for hours at a time? Or as I mentioned, that the perception is totally different if you're patient versus if you're staff in the busy ER. And so just even think about letting your staff and team know daily or weekly what it feels like from the patient side of things and how long it actually does take would be useful information for them as they think about, you know, making different alternative patient flow opportunities. EDCAHPS and HDCAHPS both have questions around communication. And they're actually laid out exactly the same. So there's the questions on both of the surveys about with nurses during the hospital stay or the ED visit, how often do they treat you with courtesy and respect? Listen carefully and explain things in a way you understand. There's the same set of questions, they just go for doctors. The top box score here, and this is one of those examples of always, usually, never, sometimes. You only get credit if they answer always. So you want to make sure these patients feel they're always treated with courtesy and respect by nurses and physicians, that they're always being listened to carefully, and that the nurses and doctors are explaining things in a way that they can understand. Some of the key areas for communication are utilizing tools that are often employed in hospitals and emergency departments at their highest level of efficacy. So if you have whiteboards, and 10 years ago, whiteboards were a pretty novel idea. Now, most emergency departments and hospitals have implemented whiteboards, but are they getting utilized regularly? Are you using it as a communication tool, not just internally, but also with patients and families? Are they designed in a way that meets the needs of the users? So if the users are patients, families, and caregivers, are you just taking something you found stock online and ordered in a big bulk and actually doesn't fit your use cases? But if you're able sometimes to get feedback from, say, patients and families and staff into the design, it's going to go a lot further in terms of actually being used on a regular basis. And then making sure that they are used regularly, like doing audits or observational audits to make sure you get feedback to make them be more effective. A bedside shift report. Are you doing the bedside shift report so that patients and families are engaged with it? This is more of a hospital inpatient type of communication tool. Utilizing a template or checklist to make sure that everything gets covered that the team is discussing with the patient as part of the team and their loved ones who may either be present or phoning in if they aren't able to be there in person. And then having observational audits related to the bedside shift report. So maybe you'd have the charge nurse doing rounding, making sure that that's happening. Team huddles are also a great way, both in the emergency department and in the hospital, that you can use. You want to make sure that you're using multidisciplinary and that leaders are involved in those huddles, and that you're doing them on care units, and you have different structures for those team huddles depending on what you need. It might be that the emergency department staff huddles at the beginning of each shift, and that there are shift handoffs, so that those are the types of things that can happen away from the bedside, but they're a great opportunity for the team to touch base and speak candidly about their experiences with a particular patient or whoever is with them. So you want folks to be responsive to the individual needs that they're serving. So I'm just going to pause here to see if anybody has any other interventions or tips that they're using for communication with patients, how to improve communication.
Janelle, a comment that came to me was that for the team huddles, they do that in an area that it's actually visible to the patient, not that they can hear them, but on admission, they let them know that team huddles do occur, because during these times that can be a stressor for people if they don't understand why staff are huddled together in the hallways.
That's a great idea. I love it. And then it would be, once they know they're huddling and meeting together with patients, I would think would make you feel good as a patient. Like, oh, they're doing a little meeting to see how they can provide care for my family member better or me better. Okay, did we skip a slide? Yeah, that one, I think. Okay, some of the tools that can be useful both in the hospital and the emergency department, and they're helpful in the ER, even though these questions aren't specifically on the ED survey, we still think they're useful things to be thinking about. So are you doing hourly rounding? And if so, is there a standard time for it? When patients are least minimally, disrupted. Are you utilizing CNAs and other type of assistants to their highest level to be able to assist the nurses in doing the hourly rounding? When you check in on a patient, are you making sure you're checking in on the 4 Ps? So pain, potty, position, and possessions. Do they have what they need? Are they comfortable? Do they need to use the restroom? Are they in any pain? And hourly rounding can help with reducing your call light usage. Ideally, patients don't have to use the call lights because their needs are being met before they even know that they have a need, because you're checking in on them. And that's a surefire way to make sure that folks are feeling confident in answering the questions when they get them on the survey in the positive. Some hospitals implement the no pass zone and setting the expectation that everyone on the team answers call lights. So it doesn't matter if you're the CEO, if you are a dietary staff, if you're in lab, if you're environmental service staff. If you're walking past a patient room that has a call light on, you poke your head in and say, hey, is there something I can get you, or can I get you someone else to help you? Anyone can provide non-clinical support. So if it's something like their possessions, they can't reach their phone, their charger came out of the wall, they need a book on a bedstand, whatever the case might be, those are the things that anybody can help with, getting a blanket. But if they do need someone to help them with positioning or pain or going to the restroom, then that person, at least poking their head in, makes that response time quicker, so that the patient feels like someone heard me, someone knows I need help, and they're going to go get that person who will be able to assist me. And that can actually decrease traffic in patient care areas if we make sure that everyone is just poking in and seeing that when the call lights come on. And then leveraging technological devices, and this gets into resourcing for sure, but at least ensuring that you have call light systems. And if so, are there different levels of, there are different levels of sophistication on those systems and what they're capable of doing. Do you have way too many speakers and nurse communication devices available? And so if someone pops into a nurse's room because they see a patient call lights on, do they have the ability, to talk to that nurse? And so even though he or she might be in another room, they know that the patient wants say a pain med, for example.
Janelle, you did have a question come in regarding the visible huddles. How do you deal with Hipaa if it is visible to the patients?
Well, I think, and I think you said this, Becky, so the patient can't hear anything, so they wouldn't know that who they're talking about, a name. So you'd want it to be not in their earshot, but it's so one hospital I worked, we called it the cage, but there were like clear glass on the upper half. And I think the point would be, you would say, tell your patients that every morning, around 8 to 9, we do patient huddles in that room. So they wouldn't know what is being said, but they would know that they're communicating about us. Does that answer the question? So there's no patient confidential information that would be visible to other patients.
It looks like it did answer the question.
Okay.
Thank you.
All right. Yeah, thanks for asking that. Okay, so medications are obviously hugely important, both in the ED and in the hospital. The questions on the survey are slightly different, so that in the HCAHPS, the questions are around, did you get told what the medication was for? And did someone describe possible side effects in a way that you could understand? And see that the green says it always. In the emergency department, they're asked, did doctors or nurses talk to ask you about all the medications you're taking? And then before giving you meds, did the doctors or nurses tell you what it was for? Did they describe side effects in a way you could understand? And then if you were told to take a medication at home before you left, did they explain what the medication was for? And so the questions are similar, but the answer choices are different for these between the HCAHPS and the EDCAHPS surveys. So when it comes to communication about medication, these are some of the key takeaway ideas for you. And if you have others, put them in the chat. So are you engaging the pharmacy? And we put this in as hospital specific, so it has that H on the side, but I've heard about it being utilized where you utilize pharmacy in ED departments as well. Can you get pharmacy involved in an interdisciplinary team huddles? How are they involved in triggering the verification process and the medication reconciliation? To help make sure that patients go home with a clear list of meds, know what what over-the-counter meds they're taking or the indications, that their record is up to date. And so when they go to the clinic, their doctor there knows what they've been taken off of and what they were put on, so on and so forth. So for patient education, that's hugely important about medications. In healthcare, we speak in a language that patients are often not familiar with, and we really need to be aware of that. We need to make sure that it's written and easy to read and in a understandable language. Every, what I want to say, kind of like vocation has their own language. So I might be great at healthcare, but I may not be good at finance language. So we need to have it in a language that's understandable for everyone. And not only like English or Spanish or something like that, but clear and simple. So if you need interpretive services, you want to have that available. You might have to need instructions in multiple language, if that's an area where you have multiple language spoken in your area. And then it needs to be provided education whenever there's new meds on a daily basis and at discharge at a minimum. I'm gonna clear my throat when I'm on mute. And then utilizing teachback as a framework to ensure that patients understood what they were told and that they can reiterate what their meds are for and what they're going to be using. And that can be, they can have electronic medical reminders or hard stops with the EHR to ensure that patient education is happening. And then utilizing keywords. So we're thinking about completing the survey. And this goes along with the kind of health literacy concept, but it just ensuring you're saying things in a way that patients can think, oh yeah, I remember when they talked to me about that because of what they said. I'm going to provide you some education about your medications, not just saying these are the side effects of your meds, but if you use some of the verbiage that's in the survey, it will ring a little bell when they go to answer it.
Janelle, something that a hospital shared with me recently is their patient and family advisory committee recommended that also at discharge, you provide both the generic and the trade name of a medication, because you often don't know what you'll receive from your local pharmacy. So I thought that was a good idea.
Yeah, that's a great idea. And for one thing, who can say the generic name?
Yeah.
Not the easy trade name. They're such big, long words. I have a hard time pronouncing some of those.
But at least if they had a reference, that would be helpful.
Yeah, and then they could look, oh, it has that big word. It's the right med, because errors do happen, right? I always check my meds, any meds I would get from a pharmacy. Okay, so cleanliness and quietness. Let's talk about that next. So that's specific to HCAHPS during the hospital stay. How often would the room and bathroom be kept clean, and was the area around the room quiet at night? And you can see always is the answer you want. Are these, and these things are, again, you want to be thinking about for the emergency room. And part of the reason is that we have some of these things framed up for both ways of thinking, even though it might not specifically be on that survey. So, we often think of services being like, oh, you came to the ED, you came to the hospital, and then we have a separate survey. But from the patient's experience, the way that they think about it, they might, they come to the hospital, especially in a critical access hospital, you come in, say, through the ED, you get admitted to the hospital, inpatient, you go home in a day or two and you go to the clinic, but it might be all in one physical building. So for them, they don't really differentiate the space, the differences. So you really want a lot of these things to apply in all areas, like cleaning. You want your clinic to look well, clean, and, not just the hospital, ED as well. And so looking at some of the things here, cleaning schedules, morning cleaning. Typically there might be a time where you do like the big cleaning, or you like where it's like more the deeper cleaning where you're mopping and wiping things down, and letting people know that cleaning is being done. And then just even the tidying up part, maybe that's done in the afternoon or the evening. Who all is responsible for that? It doesn't just, you don't want it just to be the environmental services staff, but maybe the nurse or the CNA or a volunteer that come around. And the next, the intervention, the notice of cleaning, letting people know. So being obvious about it, like maybe the cleaning staff leaves a little tent card or a calling card, or there's a note on the whiteboard. Maybe the patient is not in the room, they're down to x-ray or for a test or something while the cleaning is being done. So maybe you leave a little note saying, I was in cleaning your room, let me know if there's anything else that you want done. But it reminds them that cleaning happened. And then you want to do some cleaning auditing. So the ATP monitoring, maybe some glow gel monitoring, just even rounding inspections, like say when the nurse or the leaders are rounding to just kind of inspect and make sure that the room does look neat and tidy. Okay, and then so for the quietness of the hospital environment, it's really hard to keep an emergency room quiet, right? And it's hard to keep a hospital quiet too. And I think patients do have different expectations of quietness in the emergency room, given that, that they were there. But in the hospital in particular, you want to be thinking about awareness and structural changes that you can make and environmental noise. So with regards to awareness, do you have folks who are kind of posed as noise monitors just to make sure that you're kind of keeping tabs on the level of noise on the floor right now? Do you need to remind people to keep their voices down and providing those reminders? Maybe it's written or on an hourly basis or something like that. I've heard of hospitals that do the shush campaigns to just kind of remind people on a regular basis of what we're trying to do, that we're trying to, we want this environment so people can heal. We want to keep things quiet. And put your ideas in the chat here too, if you have ideas that you're doing at your hospitals. When we think of structural changes, it's things like enclosing nursing stations and decentralizing stations. There was a movement for a while where they had the nursing station pods in the middle of all the rooms, so it was like handy for the nurses. It's really efficient for access to care, but it can be really loud when you get all the nurses convening together in the center of all the rooms. Thinking about using carpet or floor padding in some places. I know hospitals can be pretty sterile environment, and some places they can't use carpeting, but in the areas they can, that really does help reduce the noises. And also using those communication devices as well. So we're thinking about environmental noise. Think about squeaky doors and carts and cleaning things and maintenance schedules. When are they coming in to clean the rooms? And this ties also to not interrupting people when they're sleeping if possible. And then using the communication devices like reducing the overhead noise. So, try to minimize the overhead announcements, or having the nurses use the communication devices when they're in room to room. So things like that are helpful. Anything come in the chat, Becky?
We did. It is nearly mandatory to use an earpiece for hands-free phones. It helps reduce Hipaa issues and noise.
Great idea. Thank you. I'm wondering when we're done, if you would be willing to send me those chat ideas, because we like to get ideas and just share as we talk with other hospitals as well.
Sure.
Okay. Oh, okay. So you know what? I think, like, oh my goodness, we're not done with all this information, and we don't have very much time. I wonder if we should just open it up and have people either ask questions or share their other ideas. You'll have the handouts for this.
You might, though, go through the discharge information and care transitions,
Okay.
because I know that several of our hospitals, those are two areas they struggle with the most.
Okay, so we'll go through these, and then we'll probably have to rely on handouts. And I do have a bunch of resources in the handouts that you can look at too. Okay, so related to discharge information and care transitions and HCAHPS, these are two different domains, but they're very much related in our minds. They're not related, as it turns out, when it comes to how we perform on them. Discharge information is pretty straightforward. Did someone talk to you about whether you would have help you need when you leave the hospital? Yes or no? And did you get the information in writing about what symptoms or health problems to look for when you left? Yes or no? So I often think that we may conflate the provision of that discharge information with actually helping patients understand about care transitions. These questions are a bit more broad, and it turns out nationally, this is our poorest performing area across the board for PPS and critical access hospitals. So you can actually be doing really well when it comes to discharge information, but when it comes to care transitions, we have a lot of opportunities. These are the questions during the stay for care transitions of care. Did the hospital stay? During the stay, did staff took my preferences and those of my family into account? When I left the hospital, I had a good understanding of managing what was for my health. And then when I left, I clearly understood the purpose for taking each of the medications. So those are the questions. And then we also have communication and follow-up. So it's about the ER following up with patients and your symptoms. We're going to go on to the next slide too here quick. So these are the best practices. So some of the things we can do around discharge planning and care transition is ensuring that it starts at admission. So whether we're talking about inpatient or the emergency department, we should immediately be thinking about what happens when this patient leaves, and we should be engaging them in that discussion. Social workers, care managers, or a discharge nurse, who's responsible for driving that discharge planning process? And is everybody clear that the person that's responsible, who it is, and how they're engaging as a member of the care team? Are they doing rounds and huddles? And again, that should be at the bedside, or maybe there's team huddles that change of shifts, making sure that everyone has the information that they need. And then getting that interdisciplinary involvement. Are you able to engage who's responsible for that person's care when they leave? Discharge education. Some facilities use packets or folders or binders. A lot of times you'll get an after visit discharge summary. And a technique is Teach Back. Hopefully you're all familiar with Teach Back, but that's a fantastic tool to use to make sure that you're doing a good job explaining to the patient. And then there are opportunities when you do that discharge follow-up phone call or home visits. So you're doing the phone call a couple of days, 2 or 3 days after ED or inpatient. This is a good chance to make sure that they understand their meds, or also that they're going to be getting their survey like we had talked about. If you can't do everybody, maybe selecting certain people who are at high risk for lots of meds, or maybe high risk for readmissions. So prioritize that. Some hospitals actually do home visits with their home care, or they contract with a home care agency. It's not as common, but it is a very effective strategy to when you want to improve care transitions and the transitions of care. Okay, so I'm going to stop here now. We have just 1 minute left for any comments or questions.
Yeah, Janelle, what we might do is during our next call is to continue on with our discussion. But if there's anyone who would like to have an individual conversation about HCAHPS scores and we haven't worked together specifically on it and you have some measures, the presentation today does an excellent job of almost providing a good little checklist of just really those key best practices that Stratus has found to be across the country, and we can talk about them in more detail. So reach out and I'd be glad to meet with you and set up a quick call to go over the information. But we will continue this discussion in the future, so more to come. So thank you, Janelle. We really appreciate your time today. And again, to all of the critical access hospitals, let us know your questions. We are recording the event and we'll send that out. So feel free to forward the recording to others in your organization you believe would benefit from the information. So thank you so much for joining, and thank you again, Janelle, and thank you, Ali Orwig, for all of your support and helping us with Zoom during the calls. So thank you so much, everyone. Bye-bye.